anyway, what I'm going to talk about today, and here is an outline. We're going to talk about, and there's some questions interposed in here, okay? And as I want to just, this was designed originally as an interactive talk that I gave to our neurosurgery grand rounds, but I guess you can show a raise of hands, how many, and Ryan can keep track of this because I can't see it, are familiar with multimodal brain monitoring. Which of the three describes you, just number 1, 2, or 3. And you can just, if you can just maybe type that in, send it to Ryan, and we have some type of information there. Some of them will not be pertinent, okay? And what we're going to talk about today is multimodal brain monitoring. So what is that, okay? ICP is sort of the standard that's been around for many, many years. And there are different ways to do ICP, which we'll talk about, okay? ICP being intracranial pressure. But newer technologies are coming on board where we're looking at ICP and temperature, brain oxygenation, cerebral microdialysis, cerebral blood flow. So those are what are out there. There's also, you can do brain probe EEG monitoring, all right? So there's a lot there, and most of these are done via some type of intracranial pressure bolt, all right? So what are the controversies? There'll be controversies and challenges. Some of those is lack of evidence-based medicine, a lot of institutional barriers. They're expensive. You need to have a seamless workflow, and how do you do that? And some of the problems inherent in getting these monitors, and what do they do, and what do they give us? All right. All right. If you look at the slide here, this is taken from Lancet Neurology from a few years ago, and you can see that there are a lot of brain monitors out there that are FDA approved. All right. And those of you who are interested in neurosurgery will probably be interested in the ones that are invasive. Okay. You can have, and let's go a little bit through some of these because some of your interest is on intracranial pressure monitoring. You can do this via a ventriculostomy, which is the old standard, where you put a catheter into the brain, into the ventricles, and manometrically measure the ICP. And I think next week I'll be talking about some specific case examples of that. You can also put an intraparenchymal brain monitor where you have a strain gauge or some type of fiber optic device that actually measures the brain pressure, all right? You can also do brain tissue oxygenation, and there are a couple different companies out there that have these probes that can go into the brain, and you're actually the brain oxygenation. So you're looking at the tissue oxygenation of the brain. You can do cerebral microdialysis, and what is that? It's basically functioning just like regular microdialysis, specific perfusate into the dialysis catheter. You're dialyzing small part of the brain. You're extracting small molecules, okay, less than 20 kilodalton molecules, and the most important ones are glucose, lactate, pyruvate, glycerol, any of the excitatory amino acids such as aspartate and glutamic acid. All right. So those are some of the markers that we know that are involved with brain metabolism, neuronal metabolism, as well as breakdown of cells. Glycerol in particular is in the membranes. All right. You can also do measure brain temperature, and there's also brain blood flow. There are a couple of devices out there and there's a thermal diffusion technique. We'll talk a little bit more about that, where you can actually measure the brain blood flow. So ultimately, blood flow is particularly important. And as you look through the literature on traumatic brain injury in particular, what we know is that you're guiding, how do you guide what you're doing? Okay, and cerebral blood flow is one of the ways to guide that, because you want to optimize that, because we know that the injured brain is particularly sensitive to hypotension and hypoxia, two big causes of secondary insult, which will increase the morbidity and mortality significantly. Now we know that, and those of us who take care of a lot of these patients have seen patients who actually, their brain may not look so bad on the CAT scan, but because they've had a secondary insult, a hypoxia or hypotension, that can adversely affect their outcome, so that the outcome is much worse than you. All right. Now, if there are any questions along the way, please raise your hand, and ask Ryan, and he'll direct me. I can't really see your screens or the screen because I'm looking at my slides here. All right, ICP monitoring. Let's talk a little bit about that. So this is monitoring via ventriculostomies. This has been going on since the 1970s. These are bedside procedures that can be done in the ICU, in the ER, in the OR, and basically, many of you may have seen this. You basically drill a hole that is about 5 millimeters in diameter, open the door and pass the catheter down into the ventricles. This is done using external landmarks. Sometimes this can be challenging if the ventricles are small. However, frequently the ventricles will be dilated out. How much CSF do we make per hour? We make on the order of 0.3 cc's per minute, which translates out to about 20 cc's per hour. So if the brain has to absorb all that, or if the brain can't absorb it because it's blocked, and where does it get blocked? Well, it can block at the foramen Monroe, in particular if there is pressure that's leading to swelling or edema. Okay, that's one of the places, or the aqueduct of Sylvius. Those are some of the places where you can get blockage. And if you relieve that blockage by diverting it through a ventriculostomy, that can be very life-saving, right? Now, what are the problems with a ventriculostomy? Well, it's an invasive procedure, and many times we are hesitant to place it. The patient has a coagulopathy. Many times patients are on aspirin, Plavix, Eliquis, and we don't know exactly what their coagulation status is. So that's one of the things. However, the Brain Trauma Foundation guidelines tell us that ventriculostomy is like the #1 method for controlling ICP. And again, this can be life-saving. There are some brain temperature measures that can be fixed to some of these catheters and some of these monitors. And so those are some of the caveats with ICP monitoring. All right. Okay. This is an example of a ventriculostomy we placed at bedside. This patient also had a hematoma here from an AVM. And what you can see is the blood is filling the ventricles, and these ventricles are dilated. This is a young patient, probably about 16 years old. And we can see the ventricles are bigger. So they're bigger than they would be. They should be about half that size. So the trajectory, pass the catheter down into the ventricle, cannulate the ventricle. And as you can see here, this is the CSF that emanates under pressure. And once again, can be life-saving. So that's something that early on in training as a neurosurgeon, you want to be able to master that technique. Now, the same technique, just parenthetically, of putting a ventricular catheter in is also the same technique used in shunts. All right. So you have a small kid who's got hydrocephalus for whatever reason, from a tumor or from congenital hydrocephalus or blockage of any of the pathways, they will dilate out their ventricles. And one of the things I think that was wanted to talk about is the Monroe-Kelly curve. I don't have a slide for that on this particular deck here, but what we know is that the brain can accommodate, the intracranial pressure increase. But right around approximately the ICP starts to go up, right when you have about 30 cc's of volume, extra volume, whatever it is, okay? So the brain gets compressed, squeezed, edematous, there's blood in it, and then all of a sudden the ICP will go up. And that's where the ventriculostomy can help, because you're draining off the CSF component. Now, when we talk about ICP or what's in the brain, remember the brain is like a black box. So you have in the brain, you have the brain tissue, okay? You've got the ventricular system, okay, or CSF, and then you've got blood in the brains. So very quickly, let's go through what are the ways to treat ICP that we have. Well, we talked about ventricular drainage, draining off CSF so it doesn't back up. The other thing that you can do is you can apply hyperventilation. What does hyperventilation work on? It works on the arterioles. So it works on our arterioles in the brain and causes the brain vessels to sort of constrict. So there's less blood volume, all right? The problem with that and the caveat with that is that if you go too much, the brain becomes ischemic. So then you can have strokes or infarcts. Finally, when you talk about the brain tissue itself, you want to prune the brain, get the water out of the brain. What you can do is give hyperosmotic therapy, which is mannitol, or hypertonic saline. You may have heard of 3% normal saline or boluses of 3%. those are things that you can give that will help, all right, shrink the brain and help decrease the ICP, all right? Okay. One of the controversies about ICP monitoring is, does it really make a difference? And this is for your reference. There was a trial called the Best Trip trial that was authored by Randy Chestnut and his group from Seattle, as well as others, where they randomized patients in South America and looked at whether or not there was any improvement, whether there's any difference whether you use just clinical judgment, CAT scans, versus ICP monitoring. All right, and the ICP monitoring in this case was the intraparenchymal monitor, so it's not ventriculostomies, right? And what they basically found, all right, was that there didn't seem to be a big difference, all right, in outcome. Okay? And this has raised a lot of criticisms. And you go to any meeting now in the last couple of years, this is always debated that does it mean we don't need to do ICP monitoring? Is this still the standard of care? In the US, I don't think anybody's going to give ICP monitoring because it really helps you direct your therapy. Whether you give mannitol, whether you give hyperventilation, whether you then go do an operation. All right. Some of the caveats is that a lot of CT scans and the interpretations of the CT scans, if they're tight, if they're the ventricles are small, if the cisterns are small, you may more aggressively give them hypertonic saline or the mannitol hyperventilation. Okay. Let's talk a little bit about some of these brain monitors. This is some of the monitors that are out there. This is the Lycox monitor. This is the Rometic. These are different monitors that are placed into the brain. They could be either put into the brain via a bolt type system. Again, when you say bolt, literally it means a bolt is bolted to the brain, and it gives a very secure framework for the monitor. You can also put these in directly in the brain or tunnel them directly into the brain. All right. So this is just some example of brain oxygenation. Why is this important, or is there any data for this? All right. Once again, Randy Chestnut and his group have this paper looking at brain oxygen optimization. And basically, they randomize patients whether you direct your treatment based on brain oxygenation as well as ICP, or whether you don't. And what they found, basically, and this is called the Boost 2 trial, is that those patients where you optimize the oxygenation had better outcomes. They estimate in the preliminary analysis that it decreased the mortality with severe traumatic brain injury by 10%, which is significant because nothing has done this so far. Currently, there is now a Boost 3 trial, which is a randomized controlled multi-center trial across the country where people are looking at the targeted therapy to see if you optimize the oxygenation, whether you have better outcomes. Okay, once again, another paper is showing that the improvement in oxygenation, this just peripheral oxygenation, was also associated with an improved outcome. And that makes sense because if you give the brain more substrate, and if the brain is sensitive to hypoxia, you want to optimize, okay, optimize the brain oxygenation and metabolism. Okay, clinical cerebral microdialysis has been used for nearly 20 years. Okay, clinically, in Europe, it has been approved for a long time. In the U.S., it is FDA approved in 2005. Okay, so it's been used a long time. What are the principles of it? Basically, again, you review your Krebs cycle, and the long and short of it is that you are dialyzing, okay, and sampling the interstitium. And what we know is that these small molecules, lactate, pyruvate, glucose, and oxygen are very important in brain metabolism. All right. And what's unique about the brain is that the brain is totally dependent upon glucose and oxygen. So if you don't have those, the brain will die. And that's why the brain is so sensitive to traumatic brain injury as well as secondary insults. These are very small and fine catheters. This is for your reference here. This is the tip of the catheter, about 1 centimeter, sits in the brain. And again, we focus mostly on the glucose, lactate, and pyruvate. And if you look at the lactate pyruvate ratio, that is a very, very powerful means of following and looking at the brain metabolism. So if the lactate pyruvate ratio goes up, all right, meaning that either your lactate is going up or your pyruvate is going down, all right, those are signs of ischemia. And ischemia in general, meaning the brain or that portion of the brain is not getting enough blood or nutrients or glucose or oxygen. Okay? And this just shows sort of the setup. The catheter is tunneled into the brain, put directly into the brain, either via a bolt or directly in the brain, and it's collected here every hour. The nurses need to collect it every hour and send it to the lab, where there's a device like this that analyzes it. And we have Epic, and on Epic you can see the results that are provided, right? One of the challenges with this, and the reason you don't see it everywhere, is because there's a lot of work to set up. There are a lot of regulations that are required, and there are just a few places in the country that do this. But we do it pretty routinely at our place. And one of the key factors, for those of you who might be interested in, is that this is UC Irvine, this is our hospital here, this is our clinical lab over here. So we keep the machine in the clinical lab. And initially we started this out with people running the distance from here to here. So we had runners doing this, but that lasted about a week. And what we then devised was using the tube system. So the pneumatic tube system is part of the infrastructure of the hospital. So we send it to the pneumatic tube, and the nurses love it because you send it there, it ends up over here, and then they the lab will process everything for us. So the lab takes care of the infrastructure for that. Okay. This is a summary of our experience. Okay, with this, and we use it routinely in patients. However, we reserve it for the most serious, sickest patients with either intracerebral hemorrhage, stroke, or traumatic brain injury, with a bias towards traumatic brain injury, because that's where most of the data is. This is the number of samples that are run per patient. So you think about it, we run one every hour. So basically every hour the nurses collect a sample and it's run every hour. And the number of samples per patient goes up, the more number of days you do it, with the number of catheters you have per patient. And usually we put more than one catheter, one in the good area, one in the bad area. Okay. Again, this is just some of the papers out there showing that this has been used. The group in England at Cambridge are very, very much using this. Okay. And again, in Europe, they're ahead of us in the U.S. because they've been doing this now for many years. It can be used also for cerebral microdialysis in subarachnoid hemorrhage patients. And you can find a schema. You think about with subarachnoid hemorrhage patients, what happens? They frequently get vasospasm or DCI. So what happens is the vessels start to spasm after the aneurysm, usually at day 4 or 5, but you can't tell for sure. But if you continuously monitor the brain metabolism, it has been shown that you can pick this up even half a day or so before it becomes manifest. Okay. Once again, this is in subarachnoid hemorrhage, okay? And these can be placed via a bolt or directly in the brain, all right? This is one example of a multimodal brain monitoring that one of my chief residents drew a picture of. And you can see this is a quad lumen bolt. There are 4 things that you can put in here through a single bolt that's about 5.3 millimeters in diameter. This is your Hemodex or blood flow. This is your microdialysis. This is your ICP. And this is your oxygenation. Some people will instead put EEG electrodes in there too, which can be used for looking at cortical spreading. An example of how you can put it in directly at the time of surgery. We do a lot of open craniotomies and also craniectomies, decompressive hemicraniectomy. I think you're going to hear about that in one of the seminars this month, or this set of sessions, and we put them in at the time of surgery. You just put them in at the edge of the bone flap. And the beauty of that is you have direct visualization, so you don't worry as much about hitting a vessel or hurting a vessel. Okay. Is it all about ICP? Well, this is your typical decompressive hemicraniectomy. Now, what you're doing here is you're taking the bone off, opening up the dura, putting a patch on, doing a duroplasty, giving it much more room. All right. So what you do then is and this is well known that by doing this, you can decrease the ICP to normal range. Is that all you need to do then? Is that all it's about? Well, no, because if you look at studies, and once again, I think you're going to have some talks about some of these other trials looking at traumatic brain injury, and basically both of these trials showed that although you had an increased number of survivors, the problem was that the neurological outcome was not improved. In fact, you had more vegetative or debilitated people. All right, so that has put a sort of a damper on decompressive hemicraniectomies, and we all do them, and we know that the ICPs are decreased and then controllable, and the residents love it because they never have to. I don't have to see the patient anymore because the ICPs are controlled, or they won't pick as many calls. So what this brings us to is the whole concept of multimodal brain monitoring and why we do it. Okay, because it's really not all about ICPs. There's more to it than that. And what we're starting to realize is not just ICPs. Yes, ICP is what drives us, but also optimal cerebral blood flow, optimal oxygenation, optimal energy flow, glucose utilization, delivery of glucose. All these are important for the brain recovery. All right. And so I think that a lot more of the direction in the future is going towards looking at these multimodal monitors, looking at other things, and truly optimizing the injured brain. Okay. So what is the driving force, okay, of all the problems that we face? Okay, is it, and I think that most of us, if you agree that cerebral edema is driving a lot of what's going on, all right? And why is that? Well, cerebral edema, okay, will occur around an area of injury, whether it's a hemorrhage, whether it's a contusion, whether it's a subdural hematoma. There is going to be cerebral edema that's elicited around the contusion. All right. So what is happening? There's a cascade of injury that occurs, and if you sample in this perihematoma area, this dark area here, all right, what we know is that there's a whole cascade that is going on, okay, with mitochondrial dysfunction, changes in many of the pro-inflammatory processes that are just taking off, okay? And so what many of us are doing are looking at these areas of contusion to see if we intervene, if we are able to remove the blood clot or the hemorrhage. Does that attenuate it? Well, it attenuates it because it attenuates the local pressure. But on top of that, you're going to intervene with the process of blood breakdown products, okay? Because we know that blood has what in it? What does blood have in it? It's got iron in it, right? And when iron breaks down, iron is very toxic. And so the whole toxicity of that, okay, will be decreased if you get rid of some of that. And there's major studies going on about that. Here's just a little bit about the blood flow. Okay, what we're looking at, this is the blood flow monitor, and you're optimizing cerebral blood flow. All right, and this is a measure of that. Now, the problem with this is a very focal probe, so it can measure the blood flow in one area. But also hidden in there, the estimate of the brain water content. All right, because in the blood flow monitor, there's a constant there called the K constant that is built in to help measure the blood flow. And what we know is that if you back calculate, and there's some calculations in there, you can calculate out the percentage water content that's in there. And this is a paper that talks a little bit about that. Okay. We talk a little bit about this, about cerebral edema, and this is the answer here, number 3. Okay, blood and its breakdown products are one of the big drivers for that. Now, again, we're talking about intracranial dynamics, intracranial pressure, and what we know is that traumatic intracerebral hemorrhages or spontaneous intracerebral hemorrhages to take up space. All right, and there have been 2 trials that have been done in England from very good groups, multi-center trials published in Lancet, and there's a Stitch trial and there's a Stitch trial, which is the traumatic trial. So there's both a non-traumatic and a traumatic trial. And what has been found is that removal of those clot or any type of surgery for that did not improve the outcome. All right. So that doesn't make sense, many of us said. And some of the caveats where this was done, over 10 years ago. Okay, this study came out in the 2005, 2006, that range. And that was before the routine use of navigation. Also, that was before the routine use of minimally invasive procedures. And what I'm going to talk a little bit about here is the use of minimally invasive procedures to remove a clot. What does this accomplish? This is one of the most frustrating things we see in intracerebral hemorrhage, whether it be spontaneous or traumatic, either. Okay, they're common. They happen down deep in the basal ganglia. All right, and we see it that this will progress to this very commonly. All right, you sit there, you watch the patient, you observe them, try to control their blood pressure. All right, and there have been several studies that show that if you can control the blood pressure, you can try to mitigate that. However, we all know that that's easier said than done, and this will frequently happen. All right. Once you reach this stage, it oftentimes is devastating, and there's not much you can do because the basal ganglia down here is right by the brainstem and gets severely injured. All right. So a new trial or a new initiative has been going on to try to remove these using minimally invasive techniques. Okay. And this is a minimally invasive technique that is being used, called one of the brain path technique, where you put this cannula, the brain path cannula, down into the brain and evacuate the clot. And you're working through a tube, so you're protecting the surrounding brain. You're using this targeted approach. And what I point out is that you're taking perhaps a longer approach rather than a direct approach. This is the most direct approach here, but you're going through eloquent cortex. If you go through this way here, it is a longer approach, but it is more, it spares more of the surrounding tissue, and you decrease the collateral damage. So this can be done very effectively, and you end up with nice results like this, okay? So what does that accomplish? You get the blood out of there, decrease the local mass effect, decrease the risk of it bleeding, and then you help the patient to recover because they don't have to absorb all that breakdown iron products, okay? So neurosurgeons are uniquely positioned to attenuate cerebral edema in all these ways, okay? Except, well, I think administering hypertonic saline, that's something that our ER docs do, our neurocritical care docs do. But for neurosurgery, we're doing some type of intervention or surgical intervention. All right. Here is an example of a patient who was a motorcycle accident, and you can see this blood clot here, and here, here, and here. These are multimodal brain monitors, and you see at least 3 probes right near it. All right. And we treated the patient medically and then ran out of, hypertonic saline. It started to become refractory, and therefore went to surgery using a minimally invasive procedure, going in here, removing the clot. And here's the brain monitors in there. And this is just one example of the lactate pyruvate, where it was high. Okay, this is abnormally high, and then comes down after surgery. All right, so you attenuate the edema or the poor metabolism around the brain there, okay, around the clot. Here's another example of a patient with a large clot in the head. This is a spontaneous intracerebral hemorrhage, we believe. This is one of those patients who was found down, large clot there, okay. We remove the clot. Here's the monitors here again, okay. And again, you can see the monitors in the perihematoma edema area. And what we find, okay, you get all these data here, which I'm distill here for you. Your ICPs are here, sort of the mid to high normal range. All right. Here's your blue line here, which is your brain oxygenation. It's starting out low. This here is the placement of a ventriculostomy. So at first we said, oh, this is great. We got normal ICPs in this patient, okay, or quote normal ICPs. Brain oxygenation is low. Maybe it's just bad brain. All right. And the microdialysis numbers actually were very high. And so we put a ventriculostomy in because we said, well, the ventricles look a little bit plump there. Maybe we should put a ventriculostomy and see if that helps. And what we can see here is that once we put the ventriculostomy in, the brain oxygenation starts to go up with this blue line here, all right? And the ICPs go down even lower, all right? And this is just some tracings. Here's your glucose here. So glucose was down and then went up. And here is your lactate pyruvate ratio, which was high. It started to go down, and the brain oxygenation going up. So we improved the local environment just by putting a ventriculostomy in. All right. And cerebral perfusion. This is the perfusion monitor, which is here. And you can see that once you put the ventriculostomy in here, it starts to improve. And so, again, I think what this slide points out is that the whole cascade after a traumatic brain injury, for example, is not that easy. All right. And cerebral edema is just one part of it. It's sort of the end result. But if we can get the cerebral edema under control, that can be major in helping out the care of these patients. The cerebral edema also exists with intracerebral hemorrhage or stroke. So cerebral edema is one of the things that we are constantly fighting and what drives the ICP. And once again, I go back to saying, remember we talked about how if we give the patient hypertonic saline, if we give the patient mannitol, we're driving the water content out of the brain. Well, that is the cerebral edema that you're trying to fight, all right? And however, as we know, a lot of times that is effective, but not enough. And what else can we do? And one of the things we can do are some of the neurosurgical interventions, such as placing a ventriculostomy to help with the CSF dynamics. The other thing you can do is taking out the blood clot to decrease the cerebral edema that's elicited by the neurotoxins or cytotoxins. Now, arguments, okay, about multimodal brain monitoring. Well, there's some who say that it's invasive, okay, and there are newer non-invasive techniques are out there. Always cost, everybody always argues about cost. Regional data, okay, you're talking about a small area that you're sampling, so it's not the whole brain. There's no data that says it improves outcome. It's all these case reports and trends that we see. Labor intensive, it's a lot of work. I have my residents helping out, but even so, it's a lot of work when you got multiple traumas coming in. For those who are believers in it, low risk because neurosurgeons were well trained to place these monitors. It can streamline your care. It can help you tailor your care appropriately for each patient. You can target the therapy to the at-risk areas. For example, if you put it in the perihematoma area or the area that looks like it's having a stroke, you can target your therapy to try to improve that. The information can guide us. And with improvements in IT, in particular with machine learning, we may be able to find algorithms to help us predict things far in advance before we run into problems. We're currently analyzing lactate pyruvate data, looking at trends, using machine learning to see if we can develop algorithms to predict when the patient may need a ventriculostomy, a decompressive craniectomy, or will go off the curve. Okay, we had this out there saying, who are the ones who sort of say you shouldn't be doing this? And when we polled our residents and our faculty and our people at our grand rounds, it turned out they felt it was neurosurgeons. All right. So which are you going to be? Naysayer or enthusiast? And I always had a message there for our chief residents. And this year in particular, we have a special one. And I'll stop there. And again,
Hey everyone. everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.